Well, hello, everyone. Welcome to Healing PCOS Beyond Symptoms to a Root Cause Approach. I'm Nicole with Learn Body Literacy, and I will be bringing you through the presentation today. If you have any questions, feel free to put them in the chat. I probably will not get to them till the end, but I'll go back and review everything so that we can have a chat afterwards, just to discuss all of this lovely content that is in the presentation. Okay, so we will get started. Thank you so much for being here. Starting off with the lovely disclaimer, this content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and always seek the advice of your primary care physician or other qualified health provider with any questions you may have regarding a medical condition. I am not a doctor. But what I am is a menstrual health educator, so I do still have a lot to say. So my name is Nicole. Thank you again for being here and coming to this live webinar. A little about me, if you don't know me. I began charting my fertility in 2015, and that came off of the heels of having a very bad birth control experience and looking for another contraceptive option. And then I realized, wow, there is so much to this this work, and it really changed my whole view of what charting could do, besides just this contraceptive option. So I went public with my charting in 2016, and I called it "Fam Taught Me," which was a hashtag that I started on Twitter. And then that eventually bloomed into what is now Learn Body Literacy, which is a website that I run with a lot of education and information about the menstrual cycle, as well as fertility awareness, and also courses and other live offerings. I'm also an artist. My background is in art, so I consider this sort of an extension of my art, making work about menstruation. And a lot of what I do has to do with visual learning. It's just a really good way to connect with people about this subject. And I'm also a writer, so I blog and I write guidebooks in addition to teaching my classes. And lastly, I also run a small farm and an herbal apothecary with my partner. It's called Polycultured, and there's a focus on preventative and also reproductive and sexual health offerings. So that's just a bit about me. And the reason why I'm hosting this webinar today is because I just released the PCOS Intensive. It's a 10-module course. So that's 10 different videos that are guided by me. And here's the list of all the things that you would learn in the course, and the additional resources that come with it. It's pretty comprehensive, and it's meant to kind of start you off from the broadest strokes and then move into understanding your unique factors and the root causes, and then kind of going to treating the symptoms at the end. So it's really starting off from the roots and then building on that slowly, while also allowing for modification for each person's unique needs. So check it out if you have the chance. So just to get started, what is PCOS? Maybe some of you are familiar, but for those who are not, it is a body-wide endocrine and metabolic condition. And the key defining feature of PCOS is ovulatory dysfunction. In other words, you're not ovulating as regularly and robustly as you should be. And there's an overproduction of testosterone or androstenedione, basically androgens, by the ovaries. And regularly disrupted and delayed ovulation causes a lot of downstream effects on the body. Progesterone deficiency being one of them. Obviously, the androgen excess, which is what's showing up in a lot of the symptoms. Infertility is another. And then there's plenty of other later in life risks to your bones, cardiovascular system, and your brain health. So it really is important to treat PCOS and not just suppress it. So I wanted to also talk about the name because this causes a great deal of confusion. Why is PCOS a misnomer? Well, it's because the ovaries are actually healthy with PCOS. There's nothing physically wrong with the ovary itself with PCOS. The ovaries want to release eggs. That's what they do. but they can't do so in the environment that they're in. That is the environment of too many potent androgens like testosterone. They're actually disrupting the ability for regular ovulation to occur. And very importantly, the condition is not really about cysts on the ovaries. Cysts is what is really talking about multiple normal undeveloped follicles or the egg sacs that are on your ovaries. So it's not a foreign growth that's occurring on the ovary. And I think the word cyst, it sort of implies that. Most people are thinking, oh my gosh, I have cysts on my ovaries. When actually what's happening is the ovary is filled with cysts. They're called follicles, the egg sacs that hold all of the primordial, genetic information that is your eggs that could eventually become an ovulation and be an egg released. So what you're seeing with cysts is actually a bunch of normal undeveloped follicles, and they haven't reached the point of ovulation yet, and that's why we see multiple. And it's also a metabolic as well as endocrine disorder, and that's missing from the name. And so perhaps people have debated whether we should add something about the metabolism into the name to better hone in on the root of what is occurring and kind of what the PCOS state is like. And yeah, it affects as many as 1 in 5 people with cycles. So that's quite a lot of people, millions. So here we have the typical menstrual cycle. If you're unfamiliar with what's happening in a typical menstrual cycle, I'll just kind of explain this for a moment. So in the first half of your cycle, that's called the follicular phase, you have a rise in estrogen. You actually have a rise in a couple different hormones, but the main one that's going to mature the egg for ovulation is estrogen. And so you see here on this sort of green teal color, the rise in estrogen occurring in this follicular phase. Then ovulation occurs in the center of the cycle. And then after ovulation occurs, you have a luteal phase, and that is when the hormone progesterone, that's the dark blue line in the line graph, starts to rise. So you only make progesterone after you ovulate, whereas estrogen is the dominant hormone in the follicular phase. So you've kind of got 2 halves of the cycle with ovulation in the center. And just to show you up above, the hands are referring to cervical fluid. So as we enter our fertile window, the pre-ovulatory phase, we start to generate cervical fluid. And that cervical fluid peaks around the time of ovulation before changing to a drier fluid or no fluid really present in the luteal phase. So that's typically what you would see in the menstrual cycle. And on the bottom, it's just showing you the uterine cycle, meaning that you shed your uterine lining during menstruation and then you build it up again during the cycle. So you can see that's what's going on at the bottom. In a PCOS presentation, something is going on a bit different with the menstrual cycle. And so that's what we'll be exploring in greater depth tonight. So as you can see here, the follicular phase is what is extended with PCOS. So rather than kind of having a 50% follicular, 50% luteal phase, in a PCOS presentation, you've got more like a 75% follicular phase, and then, the rest of your luteal phase. So the follicular phase is extended, meaning you're not ovulating as regularly. It's taking you a while to get to the point where your egg is going to be released. And then once it does, you have a normal luteal phase. Some people have a shorter luteal phase, but the key component here with the menstrual cycle being different from a typical cycle is that the follicular phase is extended. The body is having trouble getting that egg to a point of maturity and releasing it. And like I've mentioned a little bit so far, it's because of the environment that the ovaries are in. They're receiving hormonal messages, and the hormonal messages that they're receiving are making it more difficult to ovulate easily. So I wanted to explain as well why beyond symptoms to a root cause approach. PCOS treatment is almost always focused on symptoms. If you go to the doctor and you want to get treatment for PCOS, the treatment will mostly focus on the symptoms of excess androgens. And, that's fair. A lot of people are seeking symptom treatment. However, there are some downsides to this. One, you never have a true understanding of why those androgens are high in the first place. And secondly, you don't have a chance to build comprehensive body literacy information. And thirdly, you don't have as much of an informed choice as to how to go about treating your unique factors within such a wide umbrella of a condition. So a root cause approach starts with investigating, well, what is the cause of high androgens for you personally? And I do that in my work through a mix of menstrual charting, symptom tracking, and various clinical tests if needed. So by confronting the roots, we eliminate the symptoms, which is great, but even more so, we improve quality of life, prevent life-altering and long-term disease, and also make the transition of your menstrual life later on in perimenopause and menopause much easier, because those areas will also be vulnerable times for someone with PCOS. So yeah, it's just really important to actually start at the roots rather than start at the symptoms. And the symptoms in the normal criteria are these. One, that you have irregular menstruations or regularly have long cycles, usually like longer than 35 to 40 days or so. The second is that there are signs of high testosterone. This really is primarily about symptoms, like physical ones that you can see and observe, but blood tests can also be useful. The conundrum of this is that blood tests can also come back normal while you have symptoms of androgen excess. So I always focus on the symptoms, first. And then the last symptom is the multiple follicles seen on the ultrasound. And that is because there's multiple attempts for the follicles of ovulation to get ready in a given cycle, but none of them are being chosen as the final egg, and none of them are getting to that point where they're releasing. And that's why you see that presentation sometimes on the ultrasound. There's a lot of downstream symptoms, though, of PCOS. So, that's the core of it. But a lot happens because your menstrual cycle gets disrupted, and high androgens cause a lot of other havoc in your body. So there are things that are common with PCOS, like mood disorders, immune issues or inflammation issues, gut issues, heavy periods and menstrual pain, and liver issues. So again, it's a full body condition. Now, to place PCOS in context as well, I feel like this is really important. So patriarchal medicine has disassociated us from our bodies. That's the first thing. We're dealing with a medical system that isn't necessarily interested in us learning body literacy. So that is automatically going to make navigating PCOS more difficult. We really need to think about the intersection between what is the so-called sex hormones of estrogen, progesterone, and testosterone, and the rest of the body's symptoms, because they have an effect on every part of your body. So the sex hormones are not just for reproduction, they're for your brain and for your cardiovascular system and for your bones. They have a lot of different jobs to do. So the rest of the body systems have all of these hormone receptors. They are not just sex hormones. They're just hormones, and they're doing a lot of different jobs for you. And so menstrual cycles are not just for reproduction, they're for proper hormone production and cycling. That's why you have a menstrual cycle, whether or not you reproduce ever in your lifetime. It's because you actually are making hormones during that process. Just like the testes are making testosterone for someone with testes. It's the same thing, just in a different format with the ovaries. And we need those hormones. They do a lot of different things. And in addition to this, the medical system is broken up into specialties. So gynecology being one example. It just can't cover the wide range of body roots and symptoms that are affected by PCOS. And that leads to very ineffective treatment protocols and a lack of care, because there really isn't an intersection between gynecology and some of the other things that are going to be touched by this condition. And fertility specialists tend to be really focused on drug treatments and just getting people pregnant. And that has to do with pharma's influence on the medical system. So you don't see a lot of really like holistic, forward-thinking treatments for PCOS. A lot of it is like we need to discover this drug to, do this job for fertility purposes, and no real acknowledgement of maybe someone who does not, that's not their focus at all, of addressing their PCOS. We also have a culture of fat shaming, and this is huge when it comes to PCOS because it's carried out by a lot of people in the medical system. Doctors commonly fat shame people with PCOS. So there's lots of contempt. And that comes from physicians just telling people, oh, you should just eat less or you should just work out more, and sort of accusing you of being lazy in these things. I suggest firing your doctor if you have the ability to do that, if that's what's happening to you. That person is not invested in your healing. Furthermore, untreated PCOS plus shaming coming from a doctor or family or your peers can lead to psychological issues, eating disorders, and other terrible downstream effects. So it's definitely something that we need to really take head on when it comes to talking about PCOS. And kind of extending off of that is we have a fear of dietary fat because of fat phobia. And so that's something else that we have to fight because dietary fats are very important to healing PCOS. Cholesterol, which is an essential precursor to your hormones, is found in dietary fats. So you really need healthy dietary fats and all of the food groups. There really should be no need to do any macro elimination of any food group, carbs included, with PCOS. It's all about, how you learn about your condition, about insulin resistance, and how to treat that through food. It's not about restriction or calories or anything like that. Okay, so I hope you're all with me so far. Thanks again for being here. Now I'm going to talk about PCOS at the root. So we'll just start off by talking about this condition and how it triggers high androgens. Those androgens, like testosterone, disrupt the normal menstrual cycle. It doesn't allow the normal cycling of those typical hormones, such as follicle stimulating hormone, estrogen, luteinizing hormone, progesterone, and testosterone. And in addition, people with PCOS, because they have high androgens, they tend to also have low progesterone. If you look at that graph, that PCOS graph that we were looking at before, progesterone is only now like 25% of the cycle instead of 50% of the cycle because you have such a long period of time where estrogen is the dominant hormone. So in general, every year, for instance, you're making less progesterone than someone who's cycling every 30 days. I hope that makes sense. So there's examples here of low progesterone. You can just check them out. And in addition, we have to always think about progesterone and estrogen as being in balance with one another. As I said, the menstrual cycle has got one half where estrogen is really the dominant hormone, and then the other half where progesterone is the dominant hormone. Should be generally an equal amount of time. But low progesterone and long extended follicular phases mean that now your balance of those two hormones is off. And that means that you probably have excess estrogen. If you're not making a lot of progesterone, estrogen is left more unchecked. So you also have to deal with the low progesterone, the excess estrogen symptoms in addition to the low progesterone symptoms. So here's kind of the breakdown of you may be seeing low progesterone versus where you may be seeing excess estrogen in your cycles and in your body in general, because it extends to things like your breasts with excess estrogen. Hello to everyone just joining us. Thank you so much for being here. So PCOS has many long-term health risks, such as cardiovascular disease, fatty liver disease, and type 2 diabetes. And as such, it is a potentially serious condition, a condition that will last beyond your reproductive years. PCOS can also start in childhood and continue, the effects of it definitely, past menopause. So it's not a gyno-specific disorder. And again, that's another issue with the specialty of gynecology, kind of treating this condition when it's really a bigger condition than that. And so there are genetic predispositions that exist. However, those genes can get more activated by certain lifestyle and environment. and can be managed better with changes related to lifestyle and environment. PCOS responds extremely well to changes in diet, herbalism, and lifestyle changes. It's actually quite malleable. You can work with your cycles to change them. And I always encourage people to work on their PCOS through understanding their cycles better, because usually they can figure out what their personal, best treatment protocols are. From here, we're going to talk about what causes PCOS. It's not conclusive, of course. We think it's a mixture of genetics and epigenetics. Epigenetics is how our DNA changes function according to our environment. So these are just three main hypothesized causes of PCOS. So the first is prenatal endocrine disruption. That's an exposure to excess androgens, insulin, or other endocrine disrupting chemicals while in the womb. Secondly, there's possible hormone production during puberty. So basically like signs of that prenatal exposure not really showing up until puberty, when the menstrual cycle first gets started. And then androgen excess during puberty. So it can be just when entering puberty, PCOS is triggered by the excess androgens that are more or less normal during the teenage phase of life, and they just don't go away. So instead, you're just kind of stuck in like that puberty state for longer. And so genome-wide studies have been used to help us understand how PCOS may be inherited, why the symptoms vary widely between people, and associations found in areas are related to insulin sensitivity and folliculogenesis or ovulation. So basically they have found certain genetic markers, but those don't prove that it's a genetic condition, only that those genes can become more activated and kick off PCOS, basically. Okay, PCOS diagnosis, a process of elimination. So, PCOS actually requires ruling out similar conditions and minimizing misdiagnosis. PCOS is often misdiagnosed, and these are the top three things that it can be misdiagnosed as. So I'm just going to go over them quickly. The first is adrenal androgen excess PCOS. This is where androgen excess is coming from your adrenal glands. These are glands above your kidneys and not your ovaries. So classic PCOS, the androgens are being made in the ovary. In adrenal androgen excess PCOS, they're being made in the adrenal glands. And it's mainly triggered by things that affect the adrenal glands. So it's a different condition from ovarian androgen PCOS. It's not rooted in insulin resistance for that person or underlying conditions that impair ovulation. And you can find out or rule out adrenal androgen excess PCOS with the DHEAS test or a high prolactin test. And so that's the first thing. You just want to understand better if your androgens are coming from the adrenals, are they coming from the ovaries, or is it a mixture of both, which it can be. The next thing to rule out is hypothalamic amenorrhea. This is a condition that has many similar symptoms to PCOS, like loss of ovulation, high AMH on a blood test, and the presence of polycystic ovaries on the ultrasound. So if you were diagnosed with PCOS from only an ultrasound and an AMH test, you may want to consider whether it's actually hypothalamic amenorrhea. HA is caused by undereating carbs or undereating in general, and you can quickly figure out if this is the case by taking an LH test on the second day of your menstrual cycle or any day if you aren't cycling. And if LH is high, chronically high especially, it points to PCOS. But if LH is low, it points to hypothalamic amenorrhea. You can also kind of have both at the same time, like your body swinging back and forth between both conditions. And with hypothalamic amenorrhea, it's really that the brain-ovary communication is disrupted. So the brain just simply isn't sending the message to start up like the process of ovulation. That's what's happening with hypothalamic amenorrhea. So it's also important to understand these two similar conditions and rule out that it's HA. And then the last thing is congenital adrenal hyperplasia, which is a group of genetic disorders that affects the adrenal glands. And it's misdiagnosed as PCOS about 9% of the time. Basically, with CAH, a person lacks one of the enzymes that the adrenal glands use to produce hormones that regulate metabolism, the immune system, and other like essential functions. It's usually diagnosed in infancy or young adulthood, but milder cases are sometimes diagnosed in adults. And so there are tests for this if that sounds like it possibly could be you. The symptoms include intersex variations of genitalia, hirsutism, and other increased hair growth, and menstrual issues or infertility. So if you've ruled those three things out, or have a reasonable suspicion that they can be ruled out, you can then go ahead and make the diagnosis for PCOS. The diagnostic criteria were created by this consensus between different physicians and other researchers. It's called the Rotterdam criteria. And it basically says that if you have PCOS, you need to have 2 out of 3 of these. So you don't have to have all 3, which is interesting. And many people are going to present that way with just 2 out of 3. So the first thing is ovulatory dysfunction. The second is high levels of androgens. And the third is polycystic ovaries. And I think I just saw someone in the chat say, what if you have polycystic ovaries as shown in the vaginal ultrasound but have a regular cycle? So you would, if you have high androgens like hirsutism as well, it would basically, you have 2 of 3 present. So it'd be high levels of androgens and polycystic ovaries, and you actually don't have ovulatory dysfunction very often. So yeah, so these are the 2 of 3 present. And many people do not actually have the polycystic ovaries on the ultrasound. They're sometimes observed because you're seeing a bunch of those undeveloped follicles, which are like stunted in their process of growth. And on the flip side, healthy ovaries can also have polycystic presentation. And that's just because natural folliculogenesis occurs over many months. So there could be follicles of your future that are just getting started, and that may also present with multiple follicles on the ultrasound. So ultrasounds alone can't diagnose PCOS. It's much more about what's going on with the ovulations and like what's going on with the progesterone levels and your androgen levels or androgen symptoms. And just a bit about PCOS in teens. So the Androgen Excess Society guidelines suggest that it not be diagnosed in teens. This is because there's a lot of mimicking between like typical teenage cycles being irregular and then eventually kind of subsiding into regular cycles and PCOS. So if you are, you should have all 3 of the criteria if you're going to be diagnosed as a teenager. And it also takes about 10 years for teenage cycles to mature. So bodies actually need to gain weight around the time of puberty. That's called adrenarche, where like basically your hormones are all waking up. Your adrenal glands are waking up and you're going to grow into your adult body. And so during that time, you become naturally a little bit insulin resistant and naturally have a little bit of androgen excess. And that's why you see like acne and weight gain and moodiness and stuff during the, that phase of life. And at that time, ultrasounds may also show polycystic ovaries. So just keep that in mind if you know any teenagers that may be being diagnosed, that there's stricter guidelines around it in teens. And by about age 20, that stuff should be subsiding if the person is going to end up with, regular cycles and not develop the full-blown PCOS in the adult sense. Do you have any recs of who to test or get diagnosed with for the common misdiagnosed terms of PCOS and PCOS itself? I would use the testing for each condition. For the first 2, especially congenital adrenal hyperplasia, it may be more difficult to get a provider to test you for that without some reasonable suspicion. However, you can definitely still ask. And the first 2 should be easy to test for. You could even do the hypothalamic amenorrhea test on your own by taking ovulation predictor kits, which you can find in a drugstore. Those are testing for luteinizing hormone. And so if you take luteinizing hormone tests like every day for a week and it's high every day, that would be a sign of PCOS. If it's low every day, that would be a sign of hypothalamic amenorrhea, for example. So yeah, I would go get tested first, and then you can work with the provider on the specific condition that you actually have. I think part of it being an umbrella condition, it has the issue of unfortunately being overdiagnosed or misdiagnosed at the wrong time. There are people who need to be diagnosed who aren't, and then there are people who are misdiagnosed, and so it's a mess. Doesn't matter where in your cycle you take the LH test. The guidelines say that you should take it on the second day of your menstrual cycle. I'm sorry, can you explain what you mean by over and under? Let's see if I can just go back to that slide for you guys. Okay, so luteinizing hormone tests are ovulation predictor kits taken on the second day of your menstrual cycle or any day if you aren't cycling will help you rule this out. So, this guideline is just to take it once. What you'll find with PCOS is that it will always be high. So that's why I'm saying you can take it every day for a week. And if you notice it's high at any time, LH should really only be high 1 to 2 days of the menstrual cycle. It helps release the egg from the ovary. So it really should just be high for 1 or 2 days in the center of your cycle, like the middle. If you have regular cycles, that'd be somewhere between like day 14 and day 18 or something. And that's where you would see a spike in LH. And so that's what the tests are for. They're predicting ovulation, meaning that the egg is going to be released any moment after the test turns positive. But with PCOS, LH is chronically high. And so you'll see the LH be high at any point in the cycle. It could be the luteal phase or it could be the second day of your period, and LH is high. So that's what's the telltale sign. Oh, yes. Okay. Understood. All right. Hopefully that part's clear. Okay. Now we're going to talk about high androgens and the menstrual cycle. So what's happening with these androgens and why are they messing with your menstrual cycle? So here's how PCOS disrupts the ovarian cycle. Follicles go through a slow state of growth. That's what folliculogenesis refers to. And it starts like many months before the egg is ready to be ovulated. Some research says even up to a year. So like the egg that you're popping out this menstrual cycle, it's been in production for quite a while. In PCOS, the process of ovulation becomes stalled because of high testosterone and insulin in the ovary. So you can see here in this nice ovulatory wheel that during the follicle recruitment and follicle development stages, this is where things are getting interrupted for someone with PCOS. High testosterone and insulin in the ovary is preventing us from actually getting to the ovulation. How is that happening? Well, the outer layer of the follicle or the egg sac is known as a theca cells, and the theca cells produce testosterone. With PCOS, they are responding to lots of testosterone and they're thickening, and the follicles stall in their development process and accumulate in the ovaries rather than bursting out of their little egg sac during ovulation. So you basically are like, it's like trapping all the eggs in these like thick sacs where they can't exit out of the burst hole that they normally would into, the eventually what becomes the uterine tube and the uterus. And so PCOS cysts are actually just ovarian follicles that are in a state of partial development. And in this wheel, you can see the full development of the egg and also the follicle itself. So after ovulation, you have the luteal phase where progesterone is made from the follicle. So that's the corpus luteum is referring to here. The actual progesterone engine for your body is this temporary endocrine organ called the corpus luteum that is just an inversion of your egg sac, of your follicle that was burst from ovulation. So you can see it there. The yellow thing is is referring to that. And here's just another depiction of that. In a typical ovary, again, you're seeing like the progression of the follicle and then the release of the egg during ovulation. In the normal ovary, the theca cells are not that thick and the egg is able to pop out. In the PCOS ovaries, there's a lot of them in partial states of development, but because of the thickness of the theca cell wall, the egg is not able to pop out. Now, PCOS also affects the uterine cycle, not just the ovarian cycle. So the uterus is stalled in its proliferative phase. So that's the phase directly after the menstrual phase. That's where you build up new uterine lining after the last menstruation. So as long as estrogen levels remain high, and remember that they do because they aren't balanced with progesterone in PCOS, the uterus is told, hey, keep building more uterine lining. And that's why PCOS is sometimes associated with heavy bleeding, endometrial hyperplasia, and the passing of decidual casts, which is where you're passing a clot that's basically the size of your uterine cavity. And so PCOS and the cysts are not what's causing pain for someone with PCOS, but some of its downstream effects on the uterine cycle is mainly what's causing painful menses. So the painful aspect of menstruation, the heavy bleeding aspect of PCOS is really an effect and not a root of what's occurring. So yeah, it has to do with basically the messages that are being sent to the uterus. And if it's stuck in its proliferative phase, it only just knows how to proliferate. So if you have these long follicular phases where you haven't yet ovulated, the body during that whole time is building up more lining. So PCOS is not a static disease, but a dynamic disorder that affects the body in unique ways as you pass through life. Each one of you should be treated as individuals and have your unique condition looked at in detail. I think that is very important. And here on the right, you can see this depiction that I created of the menstrual life cycle, which shows how our hormones change in relation to one another in different stages of life. And I think it's important to understand this because basically PCOS affects you in all aspects of the menstrual life cycle, including perimenopause and menopause. All right, so we've got here so far. Hope you're still with me. Thank you so much for being here. We're now going to talk about the main subtypes of PCOS. You may be familiar with the idea that PCOS is broken down into subtypes. These subtypes are starting points for investigating your unique PCOS presentation. So it's likely there will be overlap between some or all of the subtypes for you, and that's totally okay. It's not usually that someone just is in one subtype. I like to also think of them as factors, so like some factors are more prevalent for some people than others, but it doesn't mean that all the factors aren't important. So the 5 of them are insulin-resistant PCOS, inflammatory PCOS, thyroid or nutrient-deficient PCOS, post-pill PCOS, or lean PCOS. So we'll talk about each of them. So classic PCOS is really talking about insulin-resistant PCOS. Just to explain a little bit about insulin resistance, when we eat some food, our blood sugar rises and our pancreas releases a hormone called insulin. And you metabolize your food and the body absorbs the energy from your food to fuel your body. And then blood sugar goes back down to a normal level on a nice descending arc. And then when you feel hunger again, you'll go and make some more food, right? So on the right here is a graphic showing that insulin is the key that unlocks the glucose channel. So it allows glucose to enter the cell. You can see the little yellow insulin, it's plugging into the insulin receptor, and then it opens the ability for your cells to take in sugars. And that is how you maintain a stable blood sugar and why your blood sugar doesn't get out of whack. If insulin is being regulated properly, you don't have high insulin or high blood sugar. It's just a nice process that the body goes through. And a graph of this looks like nice calm waves. And so If you look in the yellow box, this is describing insulin resistance. And on the left is what's happening with glucose, and on the right is what's happening with insulin. So as you can see on the healthy controls in blue, you don't have high insulin or high blood sugar if you're healthy and don't have insulin resistance. If you just have insulin sensitivity of a normal kind, basically when you eat food, you don't have excess glucose in your blood and you don't have excess insulin to put that glucose into your cells. However, when you're resistant to insulin, it means that you're resistant to the very small amounts that you would typically need. So you need more than normal as put out by your pancreas. And that's why you see here with insulin resistance that the person who's insulin resistant, their glucose isn't necessarily high, but they need more insulin than normal to put that glucose into the cells. And so that's why you see on the left, the glucose, both the insulin resistant and the healthy control are exactly the same. It's the difference is in the insulin. So the insulin resistant person needs more insulin than typical to put the glucose away, whereas the healthy person just needs a smaller amount. And notice that PCOS is not a case of high glucose. It's really focused on high insulin in relation to glucose. And excess insulin tells the ovaries to make testosterone. So that's the key here. For insulin resistant or classic PCOS, insulin is circulating, and that's sending a message to the ovaries, make androgens, not make estrogen, not make progesterone. It's telling it to make testosterone. So higher insulin levels mean insulin remains longer in the body, and insulin interacts with the ovaries, telling them make more testosterone. The ovaries want to put out a little bit of testosterone. That's normal. We need it. But now it's increasing its production, and that's what's messing with the menstrual cycle. And it's also causing the cycle of blood sugar and insulin to be more like sharp peaks and valleys. So you start to get this dysregulation between blood sugar and insulin. And then the below graphs, not in the yellow box, they're showing us what happens as that person develops diabetes. So the graphs are observing how diabetes develops beyond insulin resistance, first to what's called impaired glucose tolerance. As you can see in the second set, now glucose isn't being handled, right? So now the healthy control and the IGT person or the impaired glucose tolerance person, now there is a discrepancy there with glucose, and they need even more insulin. And then over the years, the pancreas, which has been working overtime, it's like, I got to keep pumping out more insulin and more insulin. Eventually, those cells start to die. It gives out, the pancreas can no longer support that process. And then blood sugar is high, and the body gets a signal to release insulin, but it's not receiving the signal. It's like stop listening to those calls and is not able to do so. And that's where the person develops diabetes, when they can basically no longer make any insulin to regulate the blood sugar. And then that's why they've got a supplement. And we're just talking about type 2 diabetes here. So yeah, those theca cells are what's making the testosterone when insulin tells them, hey, make more. So that's the relationship between the androgens and insulin, and why so many people with PCOS have insulin resistance. The excess androgens are what's causing all those symptoms, all those secondary effects of testosterone. The chin strap acne, hirsutism, hair loss, irregular cycles, all of that is coming from the androgens. And also wanted to point out that insulin is a growth hormone. It's why infants and teens are naturally more insulin resistant. Adults need much smaller amounts, but an insulin resistant adult needs more than they should to metabolize the same amount of food. So if insulin resistant classic PCOS is your issue, then treating that means improving insulin sensitivity first and foremost. It's the most important thing. There's also some other elements to insulin resistant PCOS. The first is the presence of insulin, a growth hormone, in high amounts in your adult body. It causes you to store more fat. almost like you were still growing, which makes you even more resistant to insulin. So that's part of how this feedback loop develops. Then there's specific fat distribution in the organs. So with PCOS, your body stores more fat around the organs, such as the liver, and insulin resistance feeds higher levels of testosterone and vice versa. So you've got fat storage and insulin resistance happening together. But fat cells are not just storage, they're also active endocrine cells. And so people with PCOS have more enlarged fat cells than usual. And they may have various things that are contributing to the precursors of type 2 diabetes. And this is how the disease process can go unchecked with suppressive strategies, because basically suppressing the menstrual cycle will not address any of this. And this also connects to the second subtype of PCOS. So it goes to show that these things are all related: insulin resistance and inflammation. So effects of high insulin include that sugar is stored short-term in the liver or the fat cells, and then high insulin prevents fat breakdown. And that's why it's a metabolic rooted problem. It's not about eating too much or eating badly or any of these things that people say, because you're in a different metabolic state, a more protective metabolic state where you do not want to give up any fat. You're trying to accumulate it. At least that's what your body is thinking. So changing the metabolic state is key to addressing high insulin and restoring insulin sensitivity. The second subtype is inflammatory PCOS. The immune system is very important for our natural body processes and how we fight infections, but chronic immune activation or inflammation disrupts ovulation. It disrupts your hormones and it increases androgens. So the fat cells, remember that these are enlarged with PCOS, they end up spilling free fatty acids out into the bloodstream, and that causes inflammation. There's also this process called fat necrosis, where fat cells die, and the immune system has to go clean them up. But when it does so, has to do so with inflammatory markers, basically. So you may have low-grade inflammation going on from various kinds of fatty tissue dysfunction, as well as insulin resistance. And that inflammation further exacerbates the insulin resistance. So these two are very, closely related, these two types. In addition, food sensitivities and environmental exposures add to low-grade inflammation. That's that chronic activation of the immune system that can be caused by a variety of issues. Could be possibly related to gut issues as well. So sensitivities to gluten or a protein found in conventional cow's dairy called A1 casein sometimes can be very aggravating to those with PCOS and contribute to inflammation. So the key to know whether inflammation is involved is, are there other symptoms that indicate an immune problem? Things like headaches, migraines, vitamin D deficiency, gluten antibodies, and other elevated androgens. And here's just another graphic showing us that these fat cells end up basically attracting inflammatory cytokines. Those are the little purple things. And they end up altering a lot of different body processes. So not just changing the way that the fat cells behave, but also changing what's happening in the liver and what's happening in the muscles. So contributing to insulin resistance and fatty liver as well. So there's what it's describing is this lipid spillover. And when you have that, you have systemic inflammation, and the body is constantly trying to address that and trying to clean it up. But unfortunately, that means that the immune pattern is completely disrupted. The third type is thyroid or nutrient deficient PCOS. The thyroid hormones enter all of our cells and change the way that every cell metabolizes. It rules the rate at which our metabolism functions. Hypothyroidism or slow thyroid is clearly associated with insulin resistance as well. So again, there's an overlap between two subtypes. And it's much more common for PCOS patients to have thyroid issues, specifically the autoimmune type, Hashimoto's thyroiditis. And that is also related to low-grade inflammation as well. So it's essential that your thyroid be taken care of and doing its job very well to heal PCOS. The other reason why is because it is essential for normal ovulation that the person has enough circulating active thyroid hormone, which is also known as T3. Does post-pill PCOS include post-depot shot as well? Yes. Yes, it does. Absolutely. And I feel like depot may be one of the hardest ones to kind of deal with because it's when does it wear off? Like, for each person, like when does their cycle return, So there's like an expected date of when that happens, and then there's the reality of when that happens for each person. So yeah, we'll talk about that in just a second. So insulin has two main roles in the body. The first is to pull that blood sugar out of the bloodstream and put it into the cells, and that keeps blood sugar levels down. But the other thing that insulin does is it blocks and slows the rate of fat breakdown. That's because insulin is an anabolic hormone. It helps us grow tissue and store energy. And like I said, that's why it has a role in infancy and during puberty. So if you think about this for a second, a slow thyroid means a slower metabolic rate. Plus you have high insulin, which could be blocking fat breakdown. So altogether, you can see why it's very difficult to lose weight with PCOS, especially around the organs, which really translates to the abdomen. But really what's happening underneath is not just like randomly placed fat, but it's fat around the organs mainly. Your thyroid and ovaries need minerals to regulate properly. And so you need to make sure that there are no deficiencies, especially in essential thyroid minerals such as iodine, zinc, selenium. Those can disrupt thyroid regulation and impede ovulation if they are deficient. So getting a nutrient panel can be helpful, but just be reminded that those are not always accurate. So you can just nourish your thyroid with mineral-rich foods. There's no downside to that. And if your thyroid condition is Hashimoto's specifically, the autoimmune condition, it requires immune modulation specific treatments. So with an autoimmune thyroid issue, you're dealing with the immune system attacking the thyroid gland. So the treatment needs to be immune related. It can't just be, oh, we need to treat the thyroid gland and see, if we can get the organ to function better. It can't function well if it's being attacked. So it has to be in the immune modulation area that you're looking to address the autoimmunity aspect. Okay, here's my slide on post-pill PCOS. Yeah, pill, it's become like this colloquial word for just like any contraceptive. It's kind of not great in that way because depot and the IUD can definitely also be involved. So some, not all, types of birth control use synthetic progestins, and those progestins can have a high androgen index. It basically means that if you look at their chemical structure, they're testosterone-like. So even though we're taught like, oh, progestins are just like progesterone, that's not true. So they can be androgenic or masculinizing and cause symptoms such as acne, hair loss, and other psychological effects like mood disorders. So here's a list of some progestins with high androgen indexes, including levonorgestrel, which is like in implants and IUDs, not just pills. And here's a bunch of other pills, the NuvaRing, Nexplanon, all of that is actually high androgenic. So many people will experience post-pill PCOS, but it may not be a lifelong diagnosis. If you're being evaluated when coming right off the pill, I would say your body can bounce back with natural treatments within about 6 months, unless there are other deeper issues to contend with. But this is more of a temporary thing that can be corrected. Has to do with, I guess, what I would say is that the pills have this mimicking effect, right? That puts the body in a similar PCOS state, but it should not be permanent, we hope. And then there is lean PCOS. So it's a spectrum of the same condition, and it's kind of a faulty metric because like it's just about BMI. So it's like if this person's within the normal parameters of a conventional weight range, then they have lean PCOS. There are a few interesting, aspects to how it might be different. Higher LH levels, low progesterone, and excess androgens are usually what you'll find. And most likely the insulin resistant type is what's dominating all of the other factors. And here are some specific tests for lean PCOS, which are ratio based. Because if you just look at fasting glucose, which is the typical test that they will run, it's going to most likely be normal if you're lean with PCOS. Any body type can have PCOS. That's my conclusion. But for leaner people, they tend to secrete more insulin after the consumption of glucose compared to those without PCOS. So it's like this specific hypersensitivity that the person has to insulin. And they're also more prone to reactive hypoglycemia. That's basically hangry, where your blood sugar drops really sharply about 1 to 2 hours after eating, along with increased hunger. And that's just another sign of insulin resistance. So yes, it includes people who have lower BMI. Exactly. Yeah. So here is my quick reference sheet for if you want to get tested for, each of these sort of areas within PCOS's larger umbrella. So, if you're insulin resistant, here's some ideas that you could bring to your provider. Mainly, you're getting tested for the ratios of fasting glucose and fasting insulin, or triglycerides and HDL cholesterol. Yes, screenshots are allowed. Absolutely. Take all the screenshots you need. And this will be uploaded on YouTube afterwards, so you can always go back and refer to anything in here. Happy to have you use the stuff in here, please. And so inflammation, PCOS, here's more things related to inflammation that you can get tested for, autoimmunity. For thyroid, it's really important that you look at the common antibodies that attack the thyroid. That requires a full thyroid panel. I get lots of resistance from our providers, our lovely doctors. Please test more people for their full thyroid panels and stop denying them these antibody tests. This is my PSA. It's really important to get these markers checked. A full thyroid panel should always be requested because what you're able to see is much more comprehensive than just the TSH test. You should be able to see the difference between your free and total thyroid hormones and the reverse T3 marker, which is another sign that the thyroid is going into a very shunted mode. I talk a lot about this in the PCOS intensive in the thyroid module in greater length. And the full nutrient panel also, that helps you check for any mineral deficiencies. And then for adrenal androgens, we talked about this one as well. The prolactin being high or DHES being high. And lastly, post-pill PCOS, you could kind of get tested like overall to see what's going on, like nutrient deficiencies might be common after the pill, that kind of thing. But the thyroid, I think, is another thing to really look at after pill use, or just contraceptive use, I should say. Okay, let's take on a few of these questions. About the thicker uterine lining, how easy or difficult is it to tell apart from endometriosis? Are there misdiagnoses with the two commonplace? So for endometriosis, the lesions are basically making their own estrogen, and the lesions aren't necessarily shedding. So it should be pretty easy to tell apart, because if you're having like the menstrual blood exit the body, that's not endometriosis. That's just uterine lining. So the two are difficult. With endometriosis, the person usually has pelvic pain outside of the menstrual cycle as well. So yeah, the pain is intermittent or constant, and not only relegated to around the menstrual period. I don't often see misdiagnosis with PCOS and endometriosis. However, I could see how that's possible. Like, yeah, because there's there's a lot of misdiagnosis in the gynecological community. I could see where heavy periods are just, misdiagnosed as endo. That would be it would lack a lot of foresight on the doctor, I think, to conclude that, because endometriosis really needs a surgical diagnosis through laparoscopy. So yeah, it wouldn't be wise to make a diagnosis on that. Whereas with PCOS, if the person has long cycles and polycystic ovaries and high androgen symptoms, it's pretty easy to diagnose one. Is the overlap addressed in the full course? Yes. So the overlap between the different subtypes, yes. The overlap between endo and PCOS isn't really discussed. But I am going to work on making some endo specific resources for my folks with endo out there. If I can speak to any issues with progesterone and thyroid testing. Yes, so progesterone I mainly measure through fertility awareness because it's a much more stable way to measure progesterone rather than the blood tests, which would need to be conducted after ovulation in the mid-luteal phase. But for someone with PCOS, it's very difficult for them to determine because they don't have regular cycles when they're in their post-ovulatory phase. So progesterone would be really hard to test for if the person doesn't have body literacy and they're getting tested on any old day. And then for the thyroid testing, I don't believe that it's cycle specific. Maybe your provider will guide you on that, but usually, for instance, if you have thyroid antibodies, you'd have them at any point in the cycle. Can this be compared to concerns surrounding fibroids? Yes, because fibroids are connected to estrogen metabolism, or how well your body is able to excrete estrogen, basically how it uses, and then gets rid of the estrogen that it makes. So in the overlap, I guess, between the two is that with PCOS, you have an imbalance between estrogen and progesterone with a heavier time on the estrogen. And so that can cause the development of various estrogenic issues like fibrocystic breasts, fibroids. Basically, estrogen is like a growth hormone. It helps grow things. And so when it's left unchecked and progesterone isn't there to balance it out, you see a lot more growth-related issues, things like ovarian cysts and fibroids, for example. Why is HbA1c normal in lean PCOS, some people with PCOS? I don't have an answer for that. I'm not sure why. I think it has to do with the development of insulin resistance. It also has to do with faulty testing. So like a lot of these tests were developed for other reasons, or they were tested on men. And our menstrual cycles are very dynamic, changing the conditions. And so, yeah, I think that for both these reasons, it means that basically testing may not be that useful. That's why I focus on fertility charting and measuring the hormones that way, as well as looking at symptoms as kind of the guide over testing. Low progesterone sign of non-robust waking temperatures during the luteal phase. What does that mean? Not very pronounced temperature peaks. Yes, give me just one moment. We will get there in the presentation. I will bring us there now. I'll actually talk to us about the chart specifically. So PCOS care is preventative healthcare. PCOS affects the whole body. For example, testosterone causes arteries and menstruators to constrict, but we generally want them to be dilated. So when your arteries are constricted all the time, you are diagnosed with hypertension. In a person with regular cycles, the arteries are balanced in each half of the cycle. So estrogen makes you retain sodium in the first half, and progesterone is a natural diuretic. So in this and many other ways, addressing PCOS in young people is preventative healthcare, especially as you age and go through the different stages of menstrual life. Towards the end, especially where the regular pattern of estrogen and progesterone starts to destabilize and transform, I believe that it's very important that we have healthy menstrual cycles during our menstrual years, and that confers more protection to us in the later stages of life. And PCOS is obviously, it's a condition of not having regular menstrual cycles. So that is why I am so interested in activating more young people to take charge of their PCOS. Okay, lovely. Now we can talk about the waking temperatures and what that might look like with PCOS. So I teach the fertility awareness method. Some of you may be familiar with it. Some of you are probably like, what is this? But it's the process of charting your 3 fertility signs on a graph. The graph is a combination of a line graph and a bar graph. The line graph is our daily waking temperature, and our bar graph is a measure of our cervical fluid on each day of the cycle. And essentially what you're seeing here in the temperature graph is the rise in progesterone that occurs after ovulation. So we can see when we ovulated in retrospect, and we can also see how long our luteal phases are and how robust those luteal phase temperatures are. And then with cervical fluid, we're looking at the hormone estrogen. How much estrogen is the person making? Are they making a single pre-ovulatory cervical fluid patch, basically estrogen that peaks and then results in ovulation? And do they have estrogen levels high or present in the luteal phase, when really progesterone should be the dominant hormone? So you can see all of that and more in a fertility awareness chart. So let me just give you an example or a couple examples of what PCOS charts can look like. So on the left here, we have a typical chart of someone with a regular menstrual cycle, me. And this is a 33-day cycle. And that's like on the high end of, I would say, of my cycles. They tend to be somewhere between 29 and 33. They're never exactly the same. So in a typical cycle, you have a less than 35-day cycle length. You have one single preovulatory cervical fluid patch that results in ovulation, and then after you have postovulatory dryness, where the cervical fluid changes. It dries up and it's not as present at the vulva. There isn't a lot of slipperiness left or anything. And then you see a robust temp rise. What that means is that the temperatures are all above the cover line, which is something that we learn to draw in the fertility awareness method. And that, I believe, I share in session 2 of the PCOS intensive, where you learn about the cover line, how to draw it, how to delineate between the pre-ovulatory and post-ovulatory temperatures. And then in the PCOS chart on the right, you see something a little bit different. So the cycle is instead more than 35 days. In this case, it's 41 days long, and it may be irregular from cycle to cycle. There's also, if you look at the bar graph, multiple preovulatory cervical fluid patches, which means estrogen was like circulating, trying to get to its peak, but maybe it wasn't able to do so, and then it had to try again. And post-ovulatory wet cervical fluid as well. So the person may continue to see loss of cervical fluid in the post-ovulatory phase, which signifies that estrogen levels are still circulating and high. And the temp rise may be robust, so it could look like a normal luteal phase, or the temp rise may be struggling, which would show that progesterone is weaker than it should be, which is another common presentation. So let's look at that a little closer as well. So here are 2 PCOS charts, both In the 40-day range, the first one on the left is 46 days, and the one on the right is 41 days. The one on the left shows a long cycle, so ovulation is delayed, multiple patches of cervical fluid, that's on the bar graph. The little blue bars that you see that are higher than the gray bars are showing that there's been multiple patches of cervical fluid, lots of fluctuating estrogen. And then their temp rise after ovulation is very weak. So the temperatures are less than 2 weeks long. So it looks like they only had 8 days perhaps of luteal phase temperatures, maybe even just 7 days actually. And sometimes the temperature drops below the cover line. So these are signs that the luteal phase and the progesterone levels are not sufficiently high in that cycle. On the right, you have another example of a long cycle with delayed ovulation and multiple patches of cervical fluid. So those two things are the same. But on the right, there's a normal temp rise and adequate progesterone is being made. The only real issue is that the cycle is so long that estrogen and progesterone are not quite balanced still. But the positive on the right presentation is that at least a person is making enough progesterone when they do ovulate eventually. And there are other things that you can see in PCOS charts. So on the left is an anovulatory cycle. So you can see if the person is not ovulating at all, that's no temp rise. So you don't see anything above the line. Very little cervical fluid. That shows that the person has low estrogen, not high estrogen. And the potential for hypothalamic amenorrhea concurrent with PCOS is possible if this is the chart that you keep seeing over and over. Basically, a lateral chart that does not have a temp rise at all. Could be a sign that perhaps you have hypothalamic amenorrhea, where the brain is just not sending the message to the ovaries to start the process of ovulation. That could be happening at the same time or instead of PCOS. And then on the right, you have another PCOS chart with delayed ovulation. So again, going into the 40s or so for the full cycle length. Excess cervical fluid. So as you can see on the bar graph, that person, unlike the person on the left, is making cervical fluid almost every day, especially of peak quality, types that are associated with high fertility or high estrogen, and a normal temp rise at the end. So they have a 2-week-long luteal phase at the end, but instead of ovulating in the teens, this person ends up ovulating on day 26 or so. So these are the ways in which PCOS charts can be diverse. But PCOS charts are a very useful, bio-individualized, and autonomous diagnostic tool. So contrary to popular belief, charting with FAM can be a tremendous asset for body literacy if you have PCOS. And here is another lovely reference sheet of the markers to look for if you have PCOS and what you might be seeing in your charts. So the first thing is the range of temperatures. That's, if you can see here on the left, that's the lowest low temperature and the highest high temperature. That's your temperature range. And so you want to know what's going on with your temperature range because it can let you know about your thyroid state and your metabolic state. So if you're dealing with a slow thyroid, you're going to tend to have lower temperatures than normal. If you're dealing with a fast thyroid, which is just another form of thyroid dysregulation, you'll have higher temperatures than normal. And you might want to test that for 1 to 3 cycles before confirming that the thyroid is having an issue via temperatures. You can also look for the thermal shift. That's where you see the change in temperatures from low to high. If you don't see one, that indicates no ovulation has occurred. And even if you have a bleed, it's an anovulatory bleed, not a post-ovulatory menstruation. You could also see things like spotting on your charts that would indicate low progesterone. Short cycles could indicate a luteal phase deficiency. So again, low progesterone, sporadic mucus patterns or watery fluid in the luteal phase, signifying too much estrogen, as well as observing a lot of menstrual blood. Heavy menstrual bleeding is another sign that estrogen levels were very high that cycle. And that's what built up all that blood, all that uterine lining that's being released. And sporadic mucus patterns, but little to no wet quality cervical fluid can also indicate anovulation or low estrogen. So basically, you have a really nice window into yourself for understanding yourself through fertility awareness with PCOS. It's not typical menstrual cycles that you're charting. However, you can coax your body to get to healthy menstrual cycles by understanding these specifics and how that looks for you. And I bet no one in this call would have the same 2 menstrual cycles. Even if they are regular menstrual cycles, they still won't be the same. But with PCOS specifically. Are there any apps or websites that help with PCOS charting? I so far am the only one I know of. In the PCOS intensive, I built out charting in every aspect of the course. But as far as I know, I'm the first person to do it. I don't actually think there's much else out there for charting specific. So that's what I wanted to, why I wanted to make this course specifically. And I don't have any FAM charting classes coming up. I did release Intro to Fertility Awareness on my site, which is another self-study class. I probably will teach another group class soon. I will definitely update you guys on that. And charting, it's not super beneficial when on hormonal contraceptives because that basically puts you in this territory here where you have an anovulatory cycle. So the chart would look like this. It would just go across. You wouldn't see any ovulation. And sometimes it'll even be like erratic temperatures. So the chart won't make very much sense, but you can use it to practice. And also you can, with certain contraceptives, see ovulations, such as sometimes the copper IUD allows for ovulation to continue. Yeah, so there's a few contraceptive methods where ovulation may happen, maybe not every cycle, but some cycles, so you would be able to see it then. And you can still use it to chart your cervical fluid just to see like what's going on with your estrogen levels while you're using the contraceptive. I guess in that way it could still be helpful. But I find that it confuses people sometimes because they're like looking for something, but the chart looks completely wild. So yeah, just keep that in mind if you want to try that. Okay, so we're going to move on to talking a little bit about inflammation versus autoimmunity. If you are unfamiliar with what autoimmune diseases are, it's basically when the immune cells produce antibodies against our own tissues. That process can be normal, but is kept in check by other immune cells. And autoimmunity happens when the process goes on unchecked, allowing the immune system to attack the body as if it is a foreign pathogen, and this causes chronic inflammation. With PCOS, the entire immune pattern is disrupted, and many of the same cytokines present in autoimmune diseases show up with general inflammation from PCOS. So there are big overlaps there. And I also wanted to make you guys aware of this concept that I've been researching called the Immuno-Menstrual Axis. It basically describes communication and interrelationships between the immune system and the menstrual cycle. So when the hormone levels fluctuate during the cycle, the reproductive system undergoes distinct differences in immune function in each of those phases. And menstruation and ovulation are menstruation is an inflammatory event triggered by a drop in estrogen and progesterone levels. So both ovulation and menstruation are immune events, which is something that I only realized recently, which I find very fascinating. And the immune system is integrally linked to menstruation because it requires an infiltration of immune cells that actually facilitate the endometrial shedding and tissue repair and prevention of infection. So after menstruation and during the follicular phase, high levels of estrogen interact with immune cells and attach to their receptors, changing their cell processes. In a typical menstrual cycle, estrogen is only high for a short period of time in the follicular phase, and one has higher immunoglobulin A antibodies and an increased inflammatory response during this window. However, dysregulated cycles, which are characterized by prolonged exposure to estrogen, like PCOS, are correlated with higher disease risk and cancer risks. The menstrual cycle's immune function operates in balance. So in the first half of the cycle, you have certain immune cells like type 1 helper T cells and their cytokines, and immunoglobulin A antibodies, which help protect the body from foreign pathogens. So it's basically during the first half, you have a higher inflammatory response because of estrogen being high in the preovulatory phase. But you don't want to have that constantly because it's overactive. Whereas in the luteal phase, the immune state changes. It's characterized by immunoglobulin G antibodies, innate lymphoid cells, and type 2 helper T cells. And that switch promotes a different kind of immunity that, it has to do with reproduction and potential conception. But during the luteal phase of the cycle, or the secretory phase of the endometrium, there's a large increase in different immune cells that come in and are involved in the process of menstruation. So the menstrual cycle is known to be affected by acute immune events and its dysregulation associated with chronic immune conditions. So if you really think about it, most of the reproductive health conditions are all related to the immune system in some way. PCOS, endometriosis, the list goes on. So it's just really, really interesting how tightly linked these two body systems are. Okay, PCOS and the microbiome. I just have been learning about this a lot recently as well, that there's a connection between the microbiome in the gut and PCOS. It's been acknowledged, but we don't really know nearly enough about it. Maintaining a healthy microbiome, of course, is an important strategy for preventing chronic disease because 85% of our immune function takes place in our gut, in the layer underneath the gut lining. It's called GERD. The gut is also involved in the production of neurotransmitters that influence our mental and emotional health. In PCOS, elevation of Bacteroides vulgatus in the gut microbiome was associated with altered bile acid metabolism, and the researchers ended up getting mice to sort of produce a PCOS-like phenotype through its metabolite. So basically, they found that changes in the gut microbiome were connected to insulin resistance and ovarian dysfunction, as well as the fact that androgens themselves can alter gut permeability and the composition of gut bacteria. So gut dysbiosis contributes to major PCOS factors like insulin resistance and inflammation. So if gut health is an issue for you, that's definitely something to address. There's also changes in the cervical fluid for those with PCOS. This was a study that looked at cervical mucus crystallizations in PCOS women and found more L-type mucus, which is more of like a non-peak mucus, you could say. And they also found atypical mucus crystallization with anovulatory menstrual cycles and crystallization resembling G-type mucus, which is another anovulatory mucus. So basically, they saw more mucus that is associated with the non-fertile period, or basically showing that with PCOS, the cervical fluid is disrupted, as well as the menstrual cycle pattern of ovulation happening regularly. I just thought that was pretty interesting. I just came across this research recently. I also wanted to touch on long COVID and PCOS because it's very relevant these days. COVID and its downstream effects, such as long COVID, may cause lasting or permanent damage to every organ in the body, and the menstrual cycle acts as a barometer of our health. So it helps us to see when something is wrong. In other words, it's a vital sign. And COVID may affect the reproductive system directly by infiltrating places like the uterus or the ovaries and like directly destroying reproductive tissues, or it may impact the cycle in other ways, as we've talked about a lot in this, like this whole presentation. Basically, PCOS is a full body condition. So here are other ways that the cycle can be impacted. The brain, if the brain ovary communication is disrupted in some way, That can result in premature ovarian insufficiency or failure. Basically, the body stops ovulating. Increasing insulin resistance by damaging the pancreas or through other pathways. COVID and long COVID is associated with like sudden onset insulin resistance. Increasing inflammation through chronically circulating immune markers or the development of autoimmunity. Adversely affecting the thyroid function through thyroid toxicosis, which is basically like a thyroid storm where there's like your thyroid hormones are just like going to such an extreme degree that it can even cause cardiac arrest and things, or triggering autoimmune thyroid disease. And adversely affecting fertility, such as like successful implantation of the embryo or causing early miscarriage through clotting issues with the placenta. So the takeaways are the way that PCOS presents has a lot of overlaps with long COVID. So I could see a lot of people with long COVID just suddenly having the PCOS symptoms because of these above pathways. And they're both life-threatening. They need to be treated. They can't just be like suppressed, or there isn't some like psychological assessment that can be done that can fix these things. They're physical issues. And then my last takeaway is to not lose complete hope with long COVID or PCOS, because we can treat both of them. I think to, varying degrees of success, hopefully good success. But I myself just in the past 2 years worked on a case of reversing premature ovarian insufficiency. So the doctors were basically saying, oh, you'll never ovulate again at like the age of the mid 30s. So we just worked on that for, a year, and the ovulation came back, the testing came back normal after, the charts started to look normal. So I think there's a lot of room for healing with this, but it's good to understand what's going on there. Okay, so thank you so much. If you are still with us, I really appreciate it. I know this is long, but we're getting to the end. We're going to just talk a bit about treating PCOS. So where to start with this? You need to locate your subtypes or your factors and then work from the roots of those. So this is, again, just like quick reference material, but obviously not a comprehensive list. I go into much more detail in the course about, each of the treatments for each subtype. But this is kind of like the areas that I would go. So for insulin resistance, you might want to work with things that are insulin sensitizers. For inflammation, you want to work with things that promote anti-inflammation and gut health. For the thyroid, you may want to supplement with the thyroid or work with minerals that help nourish the thyroid. If the case is autoimmunity, you've got to go back to immune modulating protocols that can help reduce the autoimmunity as well. For the adrenal androgens, you got to work on things that are going to improve adrenal health. So I've listed a few of those. For post-pill PCOS, I really like the Donquai and Vitex combination. It seems to wake up that brain-ovary communication that's been suppressed, and that seems to be very helpful. And then for all types, I have here the 4 pillars of PCOS healing that I go over in the course: nourishment, movement, rest and sleep, and nervous system regulation. I believe you need a bit of all of those to properly treat PCOS. And it's not just about taking whatever supplements. I think there's also skills to be learned here to effectively not just treat it in an acute sense, but to like manage it for, long term, like how you're going to make changes. So if I had insulin resistant PCOS, I would learn how to measure food insulin demand. That's basically understanding the different insulin secretion of different foods and how that affects the insulin demand of the meal, depending on how much of each food that you eat. So I do go over this as well in the course in greater depth. But you can also look up charts of food insulin demand to understand which foods have a higher insulin demand than others. For inflammation PCOS, I would probably focus on sleep hygiene, minimizing blue light exposure, and building anti-inflammation rituals and habits. For the thyroid, I would definitely learn to chart my temperatures for thyroid to monitor what's going on. and reduce environmental exposures that negatively impact the thyroid. For adrenal androgens, it's all about tactics of nervous system regulation. And also, if you're experiencing adrenal fatigue, you may need to reduce vigorous exercise for some time while you're experiencing that exhaustion. And then you can return to normal exercise later. For post-pill PCOS, I would probably develop a 3 to 6 month recovery plan and then stick to that and see at the end of that what's going on with your charts. And for all types, again, the 4 pillars are skills to be learned. Okay, taking the next steps. So healing PCOS is not accomplished with one supplement or even one tactic. It's about learning to listen to your body's signs and nourishing its unique needs. So I'll just go over with you what I would do from here, basically, at the end of this lovely webinar. So first, I would identify your unique factors and rank those factors by importance. So I actually do this in the course. In session 1, we go over several quizzes that go into each of these factors. But you kind of have an overview of the factors. So I thought I would share with you this little table that I made that you can kind of use to understand where's the biggest factor for you, which thing do you need to focus on, because this is like huge umbrella condition and maybe overwhelming all this information. So this really helps. It helped me organize like what's going on with my body specifically. So I highly suggest identifying your unique factors and not trying to treat like everything about this condition and just focusing on the things that are most severe for you. Secondly, I would learn the skill of charting. So that I go over in the second session of the course in great detail. So I would learn the skill of charting, understand the fertility signs, and use that as my body literacy basis to understand what's going on with my PCOS. Then I would follow the protocols for the root causes first. So it's funny, like we haven't really talked about androgens and the symptoms and hirsutism and hair loss all that much, because that really comes at the end. So I would start by following the protocols for the root causes. Do you have insulin resistance? Do you have a thyroid condition? Do you have chronic inflammation? Is it located in your adrenals? Is that the main problem where you're having these excess androgens come from? You kind of need to figure all that out first. So that I go over in sessions 2 through 5. In greater detail. And then thirdly, I would then address the symptoms, and that's going to help rebalance the cycle hormones, get the menstrual cycle back to being in a typical pattern, regular ovulations and robust luteal phases, and then healthy menstruations that are pain-free. That's what we're looking for. So I go over that in sessions 6 through 9 towards the second half of that course. And then fourth, I would plan for long-term lifestyle changes that support management and reversal. So what plans do you have in the future to treat your PCOS and keep it so that your menstrual cycle stay in check, and also so that you feel good? That's extremely important, your quality of life. So for sessions 8 and 9, I focus on supporting the management and reversal through long-term strategies. And then I would use body literacy to keep tabs on your progress. Once you have these skills, you know so much clearer what's going on with PCOS, and when things start to get dysregulated again, if they do. So it definitely helps you maintain a more autonomous healing progress, I think, where you're not just like confused or relying on doctors to tell you what the next step is. Like with this, you have a lot of information, and you're really able to direct your healing, whether or not you have the support of a practitioner. And just again, if you want to check out the course, the PCOS Intensive, it's 10 modules. So like I said, it starts out with the intro, and then we go to talking about charting. Then we get into the root causes, and then about halfway through, we start to talk about the symptoms, how to balance the hormones and get the cycle back to normal. And then towards the end, I talk about the environmental factors, things like BPA and other pollutants that are definitely making an impact on PCOS. prevalence. And then at the end, we talk about nourishment, how to nourish yourself properly, how to understand insulin demand, and how to support your lifestyle with PCOS. So yeah, please check that out. And that concludes today's webinar. Thank you so much. Again, my name is Nicole. If you want to connect with me, you can find me on Twitter or Instagram at LearnBodyLit. My hashtag FamTaughtMe has years of tweets if you want to look through my charts and other fun things that I've posted. I've also got a Patreon with like a lot of blogs on it, like hundreds of blogs at this point. So if you are interested in any specific topics, I've probably talked about it there. And if you want to work with me, there's lots of resources on learnbodyliteracy.com. I have the PCOS intensive course, but I also have an Intro to FAM course if you want more comprehensive learning on how to chart. I also have Breaking Up with Birth Control, which helps you specifically get off of birth control. And I've got the Body Literacy Coloring Book, Visual Reader, and Audio Book, which is really just an overview of everything menstrual cycle related through a visual lens, or the audio accompaniment. So I hope you enjoyed those resources, and I hope you enjoyed this session. Thank you so, so much. I really appreciate it. If anyone has any last questions, I'd be happy to answer them now. Let me just take a look at the chat and see if anyone has asked anything else since I last looked. Supplements that can help the immune system. Yes. I would go to the inflammation section of the webinar. I'll post this probably tomorrow when it uploads. And the inflammation section will have a lot of overlap with the immune system. For the immune system, there's a lot of different things. I mostly focus on immune modulation, which means not necessarily strengthening the immune system, but calming it down from being overactive. So if you look up something like immune modulating herbs or something like that, you can find a good list to start with, or immune modulating supplements, things that reduce certain cytokines. You can also research which cytokines are present in your specific condition. Sometimes certain conditions are associated with certain cytokines. So I often will cross-reference herbs to the cytokines. So herbs that are specifically active against those cytokines, and that will kind of lead you down a path of finding the right things. Thank you so much, everybody, for coming. Really appreciate it. Thanks for all of the kind words and support. Yeah, I'm really trying to just get this research out there. I'm so motivated by just the power of sharing all this. So, you know, I'm really, really grateful for everybody taking the time to listen, and hopefully this helps other people, you know, learn and share. Yes, it will be available on YouTube. Yes, I just will end the recording, and then it'll go ahead and send me the final video, and then I can upload it. So I will probably do that once it's done cooking. Does swollen ovaries on medical imagery be a sign of PCOS? That's a good question. If they're swollen but not necessarily showing the polycystic ovaries, I mean, I don't have a good answer to that. Yeah, it's a good question. I'm not sure. I wonder if it's related, but it could be some other reason why the ovaries are swelling. That's could also be causing pelvic pain as well. Yeah. Websites or apps to track PCOS. The charting app that I use is called Read Your Body. That's the like blue and teal green charts that you were seeing on here. There are lots of different charting apps that you could use to track PCOS. If you go to learnbodyliteracy.com, there's a section on menstrual apps that I suggest. So actually, if you go to learnbodyliteracy.com, you'll see a good breakdown of lots of different things. There's a section for fertility awareness. There's a section for different issues and conditions. So like how some people asked about fibroids. or ovarian cysts and things like that, there's stuff on there that will help you conceptualize more about what's going on with each condition. And there's also some information about like how to deal with the gynecologist and informed consent and things like that. So, or how to get safe menstrual products that don't have toxins in them. So there's lots of like publicly available free resources right on the website. It's mostly an education website, more than anything else. It's just where I house my courses and other things as well. But highly encourage you to check it out and send it to people, trying to spread the word about the site as it's grown in content. There's like so much on there. There's even like an anatomy section that you could share with your younger cousins or something. So yeah, thanks so much, everybody. I really appreciate everybody coming. And unless anybody has any other questions, we'll wrap it up for today. Thanks again. You guys have been an awesome audience. It's been great sharing with you. All right. Yeah, I think that's it. So thanks, guys. We'll see you soon. Have a good night, everybody. Bye.